Hi guys, today I will be talking about mechanical complications of MI. MI as a topic itself is very important for all the medical students, but the complications are as important as MI, if not more important. Okay, so let's start. We can divide the complications into many etiological groups. Okay, so let's see. First group will be the electrical complications or the arrhythmias. Then comes the ischemic complications, that is a reinfarction or infarct extension. Then we can talk about mechanical complications, we can talk about inflammatory complications, we can talk about systemic complications. So as a topic, so let me tell you what is the importance. So among the complications, the inflammatory complications, pericarditis and post MI interstellar is very important for your NEET PG. Among the mechanical complications, this group, the entire mechanical complications group, is important for your university exams. And among these mechanical complications, the complication of left ventricle free wall rupture is the only complication which is important for NEET PG. Apart from that, if we talk about the clinical perspective, a clinical standpoint, then the arrhythmic complications are the most important because this is what we see most frequently, and we have to tackle this on a daily basis. Okay, now we'll be focusing mostly. Now we will be focusing only on the mechanical complications. We can briefly divide over. We can divide the mechanical complications into early complications and late mechanical complications. Let me tell you that all tears, all ruptures, anything that is getting ruptured, it will rupture early if it has to rupture. And scarring and formation of aneurysm is occurring late. So we can see that the complications can be early or late. If we say there are early complications, we are talking about a ventricular septal rupture, a papillary muscle rupture, a free wall, left ventricle free wall rupture. So all the ruptures will be occurring early. If we talk about the late complications, then we can see extensive scarring is occurring, which is leading to formation of a LV aneurysm. If the rupture is contained, it can form a LV pseudoaneurysm. So how many complications are there? 1. Ventricular septal rupture. 2. Papillary muscle rupture. 3. Free wall rupture. 4. LV aneurysm. 5. LV pseudoaneurysm. So there are 5 mechanical complications. One thing which has not been mentioned here is RV infarction and RV dyskinesia. We will talk about that later. Okay, let me just tell you that among the risk factors, generally what we think in our minds is that a patient who has had many episodes of MI, who has repeated episodes of angina, has a poor prognosis. But let me tell you that for complications, if it is a first episode of MI, that patient is more at risk of developing complication. So if it is a first episode, then there is a very high risk. Okay, as compared to a patient who has MI in the past, who has angina, who has coronary artery disease. What is the reason? Because a patient who has MI in the past, who has CAD, he will be having collaterals. There will be formation of other vessels that will come and supply that zone of ischemic area. So there is ischemic conditioning. So this patient will not have any rupture tear. I mean, they can have, but they are less likely as compared to a patient who is having MI for the first time. So another thing, this was the first point to keep in mind. Second point is that females will be having more complications as compared to males. Okay, let's talk about LV free wall rupture. So to understand left ventricle free wall rupture, we have to first see what is a free wall. Okay, what is a free wall? Let's see. So, okay, if this is right ventricle and this is left ventricle, see, this is the left ventricle. What is this thing here? I am drawing the myocardium. This is the left ventricle wall. Okay, so what is this? This is the interventricular septum, and this if you like, let me draw this one more time. So this is the heart, this is RV, LV, this area is the apex, this is the interventricular septum. So what is this wall? This wall will now be the lateral wall. Sorry, my handwriting is very bad. This is the lateral wall, and this wall is the anterior wall. Okay, so when we say the free wall, what we are meaning to say is the anterior wall or the lateral wall, anything that is in the septum. So that this septum and the apex do not come in the free wall. Free wall means the lateral or the anterior wall. So when we say a free wall rupture, we are basically talking about an anterior wall rupture or a lateral wall rupture. So it will, as we said earlier, it is an early complication. So it will be seen within 7 days. Usually within 7 days of MI, this will have occurred. Let me just erase this and show you exactly what happens when there is a rupture. When there is a rupture, there is a risk of hemopericardium, which can go on and form a cardiac tamponade. So how does this occur? Let us see one more time. This is left ventricle. This is the myocardium. The wall is the myocardium. Okay, see why there is a gap here? Because now I have shown that there is a rupture. So there is a rupture here. Okay, what is just outside? What is this layer? This is the pericardium. This is the myocardium. When there is a rupture, blood will go from here to here. Yes, what will happen here? When blood will go from here to here, accumulation of blood in this part of the pericardium is known as a hemopericardium. When the blood accumulation is very fast and very rapid, it can go on and compress the ventricle, then that is known as the cardiac tamponade. Okay, now here only we will discuss one more thing. What is that one more thing? That is the LV pseudoaneurysm. When the blood is going from here to here, there is a bulging of the pericardium. See, this bulging of the pericardium is known as a left ventricle pseudoaneurysm. Why is it called a pseudoaneurysm? Because what is this layer? Outside layer this is only the pericardium. There is no myocardium. Okay, there is no muscle layer to this bulge. So it is a pseudoaneurysm. A true aneurysm will have a muscle layer also as the outer covering. So this is a pseudoaneurysm. As you can see, it is pseudo because there is no muscle layer. Since there is no muscle layer, there is a high risk of rupture. So whenever we see a pseudoaneurysm, we say that the patient needs urgent surgical repair. So how will the patient present to us? Since there is a rupture, there will be a severe chest pain. There is a rupture, there will be severe chest pain. Since blood is not going into the aorta, blood is now going here. So blood is not going into the aorta, so there will be no blood pressure. So there will be hypertension and shock. In some patients, what happens is there is first initially a pericardial inflammation. The pericardium just adjacent to the myocardium will first get inflamed. After that inflammation, then the muscle will get ruptured, and there is then leakage of blood. So when first the pericarditis appears, in those patients, first you can hear a friction rub. After you hear the friction rub, then they can have a free wall rupture. So the treatment is an emergency surgical repair. We talked about pseudoaneurysm. Now let's see the second complications. Which is the LV aneurysm. So most commonly this is the left ventricle. Most commonly an aneurysm will occur at the apex, that is the apical aneurysm. So as compared to a pseudoaneurysm, this will be having a broad neck. Let us see how there is a broad neck. First, let's see what was occurring in the pseudoaneurysm. So you can see this area. I'll draw it in a square. This is the neck. Okay, let me draw it once more here. This was the bulge. This is the neck. So you can see how narrow the neck is. It's only this narrow. As compared to now you can compare it with the LV aneurysm. This is the left ventricle, and this is this bulge here is the true aneurysm. So you can see the neck is very broad. So it will have a broad neck. This will not rupture because it has all the layers. It will have muscle layer, it has pericardial layer. though this won't rupture. Since it won't rupture, this is not that much of an emergency. You do not need surgery for this. You can manage it conservatively. What will you find on examination? Double apical impulse will be seen. Why there will be two impulse? First impulse will be coming from the apex. Okay, the apex you are feeling with the hand, you will feel the apex, and then the second, the double apical impulse is the LV aneurysm, the bulge. You will feel the bulge. So there will be two apical impulse, that is the double apical impulse. Okay. Can you name one more condition in which you will see a double apical impulse? It is hokum. In hokum you can see double apical impulse. Okay. So what will be the artery involved in a LV aneurysm? See, we are talking about left ventricle. Left ventricle is supplied by left. It will be something left side. So artery supplying left ventricle is the left coronary artery. What branch of left coronary artery is supplying the left ventricle? It is the left anterior descending artery, that is the LAD. So the artery involved in LV aneurysm is a LAD artery. What will you find on ECG? Because sometimes what will you find on ECG? There will be ST elevation. So normally there is ST elevation in MI also. How is it different from aneurysm? In MI, the ST elevation will decrease after 1 week or 2 weeks. But if the ST elevation persists, if it is present after 2 weeks, after acute MI, then we have to think of the aneurysm. Okay, there will also be Q waves, and there won't be any dynamic changes. What do we mean by dynamic changes? That means if it is a true MI, the ST elevation will keep on increasing or decreasing. But in the case of left ventricle aneurysm, there won't be such changes. There will only be ST elevation more after 2 weeks, and there will be Q waves. So think of aneurysm. How do you treat LV aneurysm? Since I said it won't rupture, so we don't need surgery for this. Surgery takes a back seat. We just have to prevent the infarct from extending. See, what has happened is the MI has occurred, there is an infarct, the infarct is very weak, so that has bulged out. We have to prevent that infarct from extending. How can we do that? We can give ACE inhibitors. We all know that ACE inhibitors will prevent remodeling, and it will decrease the afterload by decreasing the blood pressure. So it will make the LV easier to contract. So that is why you have to give ACE inhibitors. Is there a role of anticoagulation? See, if there is a bulge, then there can be a thrombus formation occurring inside the bulge. Here there can be a thrombus. So if there is a thrombus formation, then you can start anticoagulation. Otherwise, it is not necessary. Okay, what are the complications of LV aneurysm? Since there is a bulge here and there is a thrombus here, this thrombus can go and lodge into some artery, that is emboli. So besides emboli, are there any other complications? Since there is a infarct is there, this is scar tissue. The scar is a focus. The scar can become a focus of ventricular arrhythmia. So ventricular arrhythmia and emboli. What can be a third complication? See, this bulge out area is not contractile. Okay, the bulge has occurred. The bulges like this. So this is useless part. This part is not contracting. It is very weak. So there will be the left ventricle will not be able to contract. Since it is not contracting, there will be heart failure. So third complication you can write is heart failure, ventricular arrhythmia, emboli, and heart failure. So ventricular septal rupture. Why will the septum rupture in the first place? It means the patient did not get treatment. The septum got necrosed. After necrosis, there was a hole formed and there was a rupture. Something like a VSD was created in the septum. So now let's see what is the blood supply of the septum. Blood supply of the septum, the anterior part of septum, the 2/3 is supplied from the left anterior descending artery. LAD supplies the bulk of the septum. Okay, since the LAD will also supply the anterior and the lateral wall of the left ventricle, so there is an anterior MI also. So we can easily say that a ventricular septal rupture is seen with anterior MI more than inferior MI. Okay, so I just discussed now, if the patient did not get any treatment, there was necrosis of the septum and the septum ruptured. So we have already discussed this, that all the ruptures are early complications. What will you find on the clinical examination? There will be a harsh hollow systolic murmur on the left lower sternal border. So we can confuse it with the murmur of MR. So how can we differentiate? The MR will be present at the apex, but the murmur of ventricular septal rupture, so it is just like a VSD. The murmur of VSD is heard maximum on the left lower sternal border. What can be the other findings? If this is the RV and this is the LV, this is the septum. blood has gone from left ventricle, the septum has ruptured and blood has gone from the left ventricle into the right ventricle. So there will be a right ventricular S3. Right ventricle is failing. So whenever there is failure, there will be formation of a third heart sound. So there will be right ventricular S3. Since blood is not going, blood has to go down, but it is going to the right side. So there will be hypotension because blood is not going into the aorta. Okay, there is hypotension, right ventricle S3, a harsh whole restoring murmur on the left lower sternal border. How can we treat this? So if we have to treat this, basically we want that blood should go from left ventricle into the aorta. Okay, we want that the blood should go like this. So how can we make this possible? We have to decrease the pressure in the aorta. If the pressure in the aorta is very low, then the blood can easily go. So how can we decrease the arterial load? We just have to decrease the BP, decrease the blood pressure, make it easier for the blood to go from the left ventricle into the aorta. You can use nitroprusside. Okay, nitroprusside is a good drug to decrease the arterial load. Once we have stabilized the patient, then we have to go for surgery. We have to repair the rupture. Okay. So then now we can talk about right ventricular failure. Now we can talk about right ventricular failure. Okay. Right ventricular infarct has occurred. Right ventricular infarct, whenever it occurs, it will lead to right ventricular failure. So it is seen with anterior or inferior MI. So it is seen with anterior or inferior MI since the right ventricle is supplied by the RCA, right side of the circulation, and inferior wall is supplied by RCA. So the right coronary artery will supply the inferior wall of both the ventricles. So if there is RCA obstruction, there is an inferior wall MI. When there is RCA obstruction, the RCA also supplies the right ventricle. So there is right ventricular infarction. So right ventricular failure or right ventricular infarction is seen with inferior wall MI. Okay. Will be the clinical picture that you will see in a right ventricular infarction. If this is the right ventricle, this is now infarcted, it is not working. This is the right atrium. Blood is coming from here to here, but the right ventricle is not working. So blood will go back up like this. When it goes back up, what will happen to JVP? JVP is raised. What will happen to the blood pressure? Blood is not going into the right ventricle. If blood is not going into the right ventricle, it will not go into the left atrium. If it is not going into left atrium, it will not go into left ventricle. If it is not going into left ventricle, it will not go into aorta. There will be no blood pressure. So there will be hypotension. Okay, BP will decrease because blood is not going. Blood is not going. Okay, what will happen to the respi examination? See, clefts will be present only when there is failure of the left ventricle. When the left side of the heart fails, only then there is backward flow and there is clefts. But when the right side is failing, why will there be any clefts? So there are no clefts. So this is the triad of RV infarction. It is not very common to see, but this is a typical triad. What will happen if there is a severe RV failure? There will be presence of Kussmaul sign. Normally on inspiration, the JVP should decrease, but if there is a right ventricular infarction, when you inspire, the JVP will rise. Okay, JVP will rise. Kussmaul sign. So what is the management of right ventricular infarction? We have to give a fluid challenge. Why we are giving fluid challenge? See, if this is the right ventricle, the left ventricle, basically the right ventricle is not working. When it is not working, blood is not going from here to down, and so it is not entering here also. So if we give fluids, we are giving fluids. So fluids will enter. We basically want that fluids go here. We are trying to push the fluid here to here to here to here. So we are trying to give a challenge. We are trying to make the fluid go from the RV to the LV. So our aim is to increase the LV preload ultimately. What we are trying is, we are trying to maintain an adequate RV preload, and hence we are trying to improve the performance of the left ventricle. Okay, so that is why we are giving a fluid challenge. Okay, so this was mentioned in the Harrison that we have to decrease the pulmonary capillary wedge pressure and pulmonary arterial pressure. What basically this means is, if this is the right ventricle and this is the pulmonary artery, if this is the pulmonary artery, if we decrease the pressure of the pulmonary artery, it will make it more easy for right ventricle to pump blood down So that is why it has written that we have to decrease the pulmonary artery pressure. How do we do that? Best drug to do this is dobutamine. What will dobutamine do? It will increase contraction of the heart and it will decrease the pulmonary resistance. So both things it is doing. Dobutamine is the best drug in this case. Obviously, we have to first give a fluid challenge and then we can start the patient on dobutamine. Okay. Now let's see how can we diagnose this on an ECG. Now let's see how we can diagnose this on an ECG. Okay. Normally when we do an ECG, we place the leads like this. Normally there is V1 is here, then there is V2, V3, V4, V5, V6. So when we are to look at right ventricular infarction, we have to place the leads in an opposite direction. We have to place it in a mirror image. So we are placing V1 here, then V2, V3, V4, V5, V6. So you have to know the location of this lead. It is the most important. It is placed in the fifth intercostal space in the mid-clavicular line. If we do not want to do we do not want to place all the leads, if we place just the V4 at the fifth space in the mid-clavicular line, that is more than enough to diagnose a patient of RV infarction, because it has maximum sensitivity and maximum specificity to diagnose RV infarction. Normally, how do we place the leads? These leads are placed like this is actually the V1. This is actually V2, then 3, then 4, 5, 6. So you can see the V1 is on the comparatively the V1 is on the right side. So V1 is the only lead. V1 is the only lead that looks at the right ventricle. So if there is an elevation, ST elevation in only the V1, you should have a strong suspicion that the patient is having a right ventricular infarction. If we do a cath study, what do you mean by a cath study? That means we are inserting a catheter into the internal jugular vein from where it is going into the right atrium and then into the right ventricle. So then we are measuring the pressures of the RA and the RV. Okay. When we measure the pressures of the RA, a graph is found. Similar to this graph, we see this graph in the JEP also. That is what we are doing by measuring it by a catheter, or we are measuring the RA pressure. So what is important for us here is this Y wave. See, first the V wave comes, then the Y wave will come. So why this is happening? This is the end of systole. What happens after this? I have drawn a line here. What happens after this line is the tricuspid valve will open and blood will flow from right atrium to the right ventricle. This is the right ventricle and this is the right atrium. Since the right ventricle is not contracting properly, this is not contracting, so right atrium is having very high pressure because it is unable to push the blood into the right ventricle. Right ventricle is not able to fill, so right atrial pressure is very high. So as soon as the tricuspid valve will open, which is when the diastole will begin, and the tricuspid valve will open at this junction, tricuspid valve will open, all the blood will rush into the right ventricle. So the Y descent, which is normally like this, will occur very rapidly. So prominent Y descent is seen in right ventricular infarction. We can see this in JVP and you can see this on the waveform also. If we see the pressure waveform of the right ventricle, this was for the right atrium. See, this is systole, right ventricular pressure is increasing, diastole it is decreasing, systole increasing and then diastole decreasing. This is the right ventricle pressure waveform. What is happening in RV infarction is there is a square root sign, also known as dip and plateau. Why dip and plateau? This is the dip, this is the plateau, also known as the square root sign. Why is this dip and plateau occurring? See, this is the systole. Now the diastole has to begin here. What happens in the diastole? The blood will rush into the right ventricle from the right atria, so it is a rapid descent. After the initial rush, then what happens is right ventricle cannot accept more blood because it is not working properly. So then there is a plateau phase. This is the plateau phase. So first there was a dip and then there is a plateau. So this is a dip and plateau waveform of the right ventricle, which is seen in RV infarction. Have you seen these two signs anywhere else? Yes, these two signs are also seen in constrictive pericarditis. Okay, constrictive pericarditis will also have a prominent Y descent and a dip and plateau phase. So now the last complication of So the last mechanical complication of MI is acute MR. So first, if you have to understand about MR, you have to understand about the blood supply. See, this is a valve. Okay, the valve has anterior and posterior leaflets. What is this? This is the chordae tendineae. And what is this muscle here? These are the papillary muscles. One papillary muscle, this is the posterior medial papillary muscle, and this is the anterolateral papillary muscle. So what happens in a acute MR is, basically what happens in MI is, this papillary muscle will get ruptured. Okay, why the posterior middle muscle get ruptured and not the anterolateral is because the posterior middle papillary muscle has a single blood supply. And what is that blood supply? It is a branch of RCA. Okay, and we know that RCA is the one that supplies the inferior wall. So we can say that acute MR is mostly seen with inferior wall MI. It can also be seen with anterior wall MI, but inferior wall MI is much more common. What will be the clinical features? What will be the clinical features of acute MR? Since now blood is now going from left ventricle into the left atria instead of going into the aorta, there will be cardiogenic shock. There will be low blood pressure. Also, since it is going from LV to LA, it will go now into the pulmonary capillaries and cause pulmonary edema. There will be a flash pulmonary edema. Along with that, there will be a holosystolic murmur at the apex. How will you treat? So basically, we want the blood to go from the LV to the aorta. So if we decrease the blood pressure very much in the aorta, we can make it more easy for the blood to go into the aorta. So first we have to decrease the afterload. Once we have decreased the afterload, then the treatment of choice becomes surgery. If the muscle has ruptured, then the treatment of choice is surgery. So when we are doing a surgery, we have to see whether the papillary muscle has necrosed. If there is a necrosis, it means we cannot just repair it, we have to replace it. So then the treatment of choice is replacement. Otherwise, if there is no necrosis, then the treatment is mitral valve repair. So now finally we have come to the MCQ part. Let us just see the MCQs. So see, this is a very long question. Patient came. I just say what are the key points in this question. So he had an MI. After he had an MI, they are mentioning that the patient has a friction rub. Okay, they are also mentioning that the patient had a marked hypotension. There were jugular veins were distended, and there was electromechanical dissociation. What do you mean by electromechanical dissociation? It is basically now this term is not used anymore. It is now called as PEA. PEA means pulseless electrical alternance. We mean that there is electrical activity but there is no mechanical activity. That is why there is no pulse. So the heart is not contracting. And among the cardiac causes of pulseless electrical alternance, one of the most important causes a cardiac tamponade. Cardiac tamponade is a cause for pulseless electrical alternance. So do you know of any complication of MI? See, they have said that patient had MI. Okay, after MI, patient had this pericardial friction rub, patient had cardiac tamponade, and patient had distension of jugular veins and hypotension. So answer is external cardiac rupture. External cardiac rupture is nothing but free wall rupture. So I had discussed about that in the first slide, that some patients will have initially they will be having pericarditis, and after that the wall will rupture. So this patient in this case has developed a free wall rupture, and now he has gone into cardiac tamponade. So that is the answer. Okay. So next question is, what is the complication of LV aneurysm? We have discussed already if there is an aneurysm, it can lead to both heart failure, it can lead to arterial embolism, and since there is a scar, it can be a focus for ventricular arrhythmia. So answer is all of the above. Which ECG lead is most helpful in diagnosing RV/MI? Answer is V4, right-sided lead. What is the objective of therapy for RV infarction? See, when there is an RV infarction, we have to somehow make the fluid reach into the LV. This is the RV and this is the LV. So we have to give fluids. So we have to increase the preload to the RV so that the preload to the LV also increases. So we have to maintain an adequate RV preload. Okay. So we have already discussed that if this is the pulmonary artery, if we decrease the pressure inside the pulmonary artery, it will make it much more easier for the RV to pump blood into the pulmonary artery. So you have to reduce both the pulmonary capillary and the pulmonary artery pressure. So answer is all of the above. Okay, what will the catheterization study in a patient with right ventricular MI will resemble? So what was the findings in right ventricular MI in on putting catheter? There was a steep wide descent and a square root sign. So where can we find these two findings? It will be seen in constrictive pericarditis. So that thank you. If you like this video, do hit the subscribe button so that I can continue to make more such videos. Thank you.